This webcast and other accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video materials may be undertaken with prior written consent of the AARC only. Copyright 2012. All rights are reserved. My name is Bill Dubbs. I'm the AARC Director of Education and Management Services, and I welcome you to today's webcast on advanced modes of mechanical ventilation. On completion of this program, you should be able to define the principles of mechanical ventilation associated with lung protection and improved outcomes. You should be able to describe the variations in modes of ventilation and proposed advantages of each. Review the literature regarding modes of ventilation and outcomes in respiratory failure, and describe the important ventilation variables to be monitored during lung protection. I am pleased to introduce Richard Branson. Rich is a registered respiratory therapist, an AARC fellow, and a fellow of critical care medicine. He is a professor of surgery and director of clinical research at the University of Cincinnati, where he is also director of the post-approval monitoring program and a member of the adjunct faculty at both the College of Pharmacy and the School of Aerospace Medicine. Rich has contributed to many textbooks and authored and co-authored over 60 papers in the peer-reviewed literature. He is an acclaimed and frequent speaker at both national and international professional society meetings. Noteworthy is the fact that at the AARC's 2011 Congress, Rich was awarded the AARC's highest recognition, the Jimmy A. Young Medal, for his lifetime of contributions to this profession. Mr. Branson discloses that he has relationships with Breathe Technologies, Icaria, Covidian, General Electric, Advanced Circulatory Systems Incorporated. Name brands of products may be mentioned merely as examples of technology. Rich, welcome to the program.
Thanks, Bill. I hope I can get it all done. I'm hoping that I can, address these issues. When Bill asked me, Rich, talk about advanced modes, I thought, oh, that'll be easy. Yeah, that's always easy. But then you start looking at, what's new and what's advanced and what people have question about. So I tried to poll some of the adult acute care section members and just ask, what are the questions? What are the things that you want to hear about? And of course, in this format, talking about all these things, you can't talk in depth about all of them. So I picked a couple things that people seem to have questions about, some that I would consider to be fairly new, some that aren't new at all. But I think when we start with this issue of advanced modes, we're talking about not only modes of ventilation, but ventilatory techniques that have been introduced that are either proposed solutions to our limitations in current technology or known solutions to our limitations in current technology. And the more I thought about it, I thought, well, the first thing we really need to do is realize what is the best evidence. So when we talk about these, what limitations of our current best evidence are being addressed by this technique? And then once you ask those questions, can we find any improvements either in physiologic outcomes or in actual outcomes, survival, length of stay, things like that? So I think we all have to remember that regardless of the mode or the technique, whether it's a high-frequency ventilation or APRV or one of the techniques to improve synchrony, the guiding principles remain. We want to provide lung protection, so to prevent alveolar collapse and prevent overdistension. We want to have adequate gas exchange, not super normal PaO2 or absolutely dead-on PCO2, but livable gas exchange. In terms of some of the modes that are addressing synchrony, we would like to unload the respiratory muscles and relieve the work of breathing. And in some of the new techniques, we're really looking at improving comfort and synchrony. So let's start with the limitations and in terms of ventilating patients with acute respiratory failure. So here's a CT scan of a patient with ARDS, and it shows kind of the hallmarks of things that we've learned over the last 10 or 15 years, and that's that there are issues with the distribution of fluid in the lung, and the weight of the lung literally collapses on itself. So if we're looking at the area here in the back where I'm putting the stars, this is where the collapse is in the lung. Literally, the fluid in the interstitial tissue is causing these alveoli to collapse. In the ventral portion, or what we consider the non-dependent portion of the lung, you have this area of the lung that's open. And early on, a lot of people said, well, ARDS is a disease of the posterior lung segments, but it's really not. The entire lung is affected. And of course, there are a couple very simple principles here then, and that's that when you ventilate this lung, gas follows the path of least resistance and is more likely to ventilate the anterior non-dependent portions of the lung rather than the dependent portion, which has two negative consequences. The first is that you can over-distend this area as well as create a shear force injury between the collapsed and non-collapsed portions of the lung. And so our principle then of ventilating this patient comes down to we want to avoid over-distension in this part of the lung that's non-dependent, and we want to do something to recruit this part of the lung that is dependent. And obviously these can be competing goals. If you're concentrating too much down here, you can end up injuring the lung up here. And it's a balance, and we all have to learn how to take care of the patients who have these problems. So how important is this lung protective idea? So we all know that the ARDSNet-ARMA trial was published over a decade ago. They compared 6 mLs to 12 mLs per kilo, plateau pressures of less than 30 for the small tidal volume group to less than 50 for the high tidal volume group. There's a reduction in mortality of 22%, and the number needed to treat. So how many patients do you have to use a lung protective approach on to save a patient's life is 12. And importantly here, the stiffer the lungs, the greater the benefit to the patient. So it's important in all patients to do lung protection, but clearly the sicker the patient is, the more important it is. And I think this is really important. And I'm not sure, I just finished giving emergency medicine grand rounds to our guys here at Cincinnati and was telling them the same thing. In my time of working here, we have studied different modes of ventilation, different types of high-frequency ventilation, 3 different kinds of surfactant, nitric oxide, partial liquid ventilation, drugs to increase antioxidant levels, drugs to stabilize white blood cells, all at the costs of tens to hundreds to millions of dollars to drug companies and manufacturers trying to improve outcome in ARDS, and all those things failed. And here it turns out that by monitoring your patients carefully and being more precise and just turning the tidal volume down with the device you already own, you can impact outcome. And I just can't tell you, again, in the grand scheme of things over 30 years of doing this, how impressive that is to me to this day. Here's the data, and again, I'm not going to bore you with a lot of this stuff because we have a lot to do. But these are, if you look at the lines at the top, you're looking at patients who are, as the lines are falling, patients are dying. So the dark line is the patients who are on low tidal volume ventilation, and the dotted line is patients on the higher tidal volume. And you can see that for the most part, most of the deaths occur in the first week or so of mechanical ventilation, or surely the first 3 weeks of mechanical ventilation, but that the mortality benefit lasts out for 6 months. And that's actually, again, very impressive, the results of this study and the guys who put it together. I have to give them credit. Things about this, and this is my preface before we start talking about other things. This is the PO2 FiO2 ratios of the patients in the ARDSNet trial on day 1 through 21. So here's the PO2 on day 1, PF ratio on day 1, high tidal volume on baseline, high tidal volume on day 1, PO2 high tidal volume day 2, PO2 high tidal volume day 3. And look at the lower PaO2s associated with the low tidal volume strategy. Now, if you also looked at the other data, you'd find out the people who got the higher tidal volumes had better lung compliance, better PaO2, and you might have at one point in time said, well, clearly 12 mLs per kilo is better because PO2 is better. And it turns out, I just showed you the data, you just die with better numbers. So don't be fooled by these physiologic outcomes as being the answer that, we'll talk about it. I hear all the time, high-frequency ventilation improves PaO2. Well, So does high tidal volume ventilation, but it doesn't improve outcome. So be careful about being kind of seduced by that number as opposed to looking at what the real outcomes are. So there have been some really interesting studies that have come out recently that I think bear discussing as we move into the advanced modes, and that's that not only does low tidal volume improve outcome in ARDS, but it helps prevent ARDS in patients who don't have ARDS or acute lung injury. So this is from a paper that's a few years old now, but they basically put in a respiratory therapist-driven protocol so that nobody got more than 10 mLs per kilo of tidal volume. If you had any risk factors for getting ALI, you could only get between 6 and 8. Now these people don't have ALI or ARDS, but they have a risk for it. So somebody who got a multiple transfusion, somebody who has pancreatitis, there are lots of examples. This is something I wish I could tell you that they do where I work, but they still don't to this day. I think we can chart what the tidal volume is set at, but we got to get used to charting the tidal volume in mLs per kilo because it's the only way to change people's frame of reference to pay attention to what's important. They limited blood transfusions, and what they showed is that they reduced in their ICU the incidence of ALI and ARDS from about 30% down to 10% with just these simple, basically, there's no new equipment. It's just a practice of caring for patients to reduce mortality, and their ICU mortality fell in half as well. That's very powerful information. This one I think is really clever. It's from the Mayo Clinic group, so they have had an EMR for a long time. So they use this algorithm in their computer that looks at the PF ratio, the report from the radiologist, if any of the words like lung injury come up, and the data coming from the ventilator, plateau peak pressure is greater than 35 or a set tidal volume greater than 8 mLs per kilo. And if those three things happen together, they actually send out an automated page to the ICU docs, the respiratory therapists that basically say, hey, come to the bedside and figure out why this patient is at risk for getting a ventilatory strategy that is not lung protective. And it's preliminary data, but they had 111 alerts and 80 patients with a positive predictive value of close to 60%, and they were able to reduce the number of hours that patients were on these potentially injurious ventilation settings from 41 to 27 hours. So people are starting to use the technology that we have to make improvements. Again, the best thing about this to me is it doesn't require an advanced mode. You just have to pay attention to what it is you're doing. And this work from the Mayo Clinic I think is also very impressive. And I know it's very busy, but as you look across the horizontal axis, you're seeing time from 2001 to 2008. And then you're seeing all the things that they do. So if we start at the top, LUCA reduction of red cells, physician order entry, restricting their transfusion practices, and only having male donors for plasma. It shows you how many multiple transfusions they give, and you see the number falls in more than half over those 10 years. How they approach lung protective ventilation, at first with a web-based tool, then a respiratory therapist protocol, and now with this electronic surveillance. And I think anyway, in my mind, very impressively, they start out with a tidal volume of 10.6 per milliliters per kilogram in year 2001, but by the time they get to 2008, the average tidal volume is less than 7 mLs per kilo. Then you look at affecting sepsis, having a sepsis team, the decision support associated with the sepsis bundle. They do standards of care for community-acquired pneumonia, including getting antibiotics, the appropriate antibiotics within the first 4 hours. They have switched to 24-hour intensivists, and basically what you find is after they have done all this is here's their data looking at the amount of community-acquired ALI on one side and the amount of hospital-acquired ALI on the other. So you can see that over this period of time where they're making these changes, the number of patients who go on a ventilator who don't have acute lung injury and then develop it falls precipitously over this period of time. And I think it just goes to show you what you can do. So I wanted to say that because there's no use talking about advanced modes if what you're doing to begin with doesn't meet the standard of care and the state of the art, and that's where we're at. So I talked to some people and they said, well, when do we use APRV and when do we use high frequency? And I always get questions about the VDR. So I'm going to address these as the literature allows me, because quite frankly, and I'm sure a lot of you are aware, there just isn't a lot of literature on some of these techniques. So I like to show this picture because we participated in the first clinical trial of APRV with John Downs, and when we did it, we didn't use a ventilator. If you look at the picture at the top left, essentially what we did was had a down slow generator up here at the top going through a humidifier to the patient, and in here there was like a solenoid valve. Sorry, that doesn't show up very well. Let me mark it a different way. So here there's a solenoid valve, and the patient's either on 30 of CPAP or on 10 of CPAP. Of course, you could change these two pressure levels with any kind of PEEP valve that you had. And I think this is where sometimes when you hear this get explained to people, APRV's 2 levels of CPAP, that's where they get this idea. And here's the kind of classic waveform produced with APRV. And I don't have enough time to discuss how all these things work, but the proposed advantages were you'd maximize recruitment, because essentially what you were doing is you were saying, you know what, I'm going to put the patient on the CPAP level, the highest CPAP level that they can possibly tolerate, and let them breathe spontaneously, because spontaneous breathing has lots of positive effects: improved VQ matching, improved venous return, increased cardiac output. And then remember, this John Downs, along with Kirby, was one of the guys who would have been considered the high PEEP guys, wrote the paper in Chest back in, excuse me, in the late 70s. So what would normally happen is you'd be going along on this airway pressure curve here, and these guys were big IMV users, and then they'd give a breath on top of it, right? Well, if you're already at 20 or 30 of PEEP, that breath, no matter how small, is going to create a very high airway pressure. So they reasoned that they would drop the pressure from the CPAP, and this was called a release pressure. And this is where CO2 elimination occurs. And from my standpoint, APRV is just a special case of SIMV, and patients are breathing spontaneously. I mean, I dare you to try to breathe spontaneously during that half a second or quarter second expiratory time. I just don't think it happens that often. But because this was done with a continuous flow system, one of the other big things was you didn't have to worry about triggering. So the idea was that there would be reduced sedation use as well as better synchrony. So I think APRV, you have to think about it not just as it's some totally different mode, but it's a way of applying high levels of PEEP as well as allowing some tidal ventilation to occur to support CO2 elimination. 2 things I think are important to tell you about APRV. When we started the trial, there were a number of patients we'd put on 15, 18, 20 of CPAP, and their oxygenation would get better, their work of breathing would go down, and we didn't have to release the pressure at all. Then there were patients those patients didn't meet the criteria to be enrolled. The patients who were enrolled, all for the most part, did very well unless they got so sick, at which point the release times didn't help anymore, or you had to have so many release times to help with CO2 elimination that you couldn't keep the hypoxemia at bay. And somebody always asks me, well, why is this P high, and why is this P low, and why is this T high, and why is this T low, and why isn't it expiratory time and inspiratory time? And the unfortunate answer is when APRV went through at FDA, the decision was made by FDA that a ventilator couldn't have an inspiratory time longer than 4 seconds, and the I ratio couldn't be any more than 4 to 1, and therefore if it was going to do something different, it had to have a different name. So that's why we have these names. I know people think we made them up. So this is talking about the terminology for APRV, and actually Rob Chatburn and a couple of the physicians he works with at the Cleveland Clinic have done a very nice job in a couple of papers, some that are about to be published in respiratory care and some that have been published, about our understanding of APRV and how it actually works. But just to give you an idea, this is what we're talking about. From my standpoint, the important thing to remember is that when you go from this pressure down to this pressure, the patient exhales the tidal volume. And when you go from here to here, the patient gets a tidal volume. And there, in fact, then, APRV can still be judged whether it is a lung protective approach or not by the normal monitoring that we do. Okay, and this again is from a paper by, I think it's by Dr. Daoud and one of the other fellows who's now moved on, and Rob at the Cleveland Clinic, looking at what APRV looks like and comparing it to BiPAP. And I'm not going to spend a lot of time on that, but just to say that they're both pressure modes of ventilation where you set the pressure. They both allow spontaneous breathing at regardless of the cycle of the mandatory part of the breath. And really the difference is philosophically, one is more like conventional ventilation with BiPAP or bi-level, and airway pressure release ventilation again is a maximizing the the alveolar recruitment and using these releases to support spontaneous ventilation. And again, I think this Cleveland Clinic Journal of Medicine is available. I think it's open access at this point since the article is old enough. And I mean, I got to give this group credit. This was an excellent article on all the modes of ventilation and gives you some good diagrams and talks about why these things are different or why they're the same. So the thing for APRV still remains the same for me. If you're doing APRV, you're telling me that spontaneous breathing is good and you believe in all the effects. And this was based on this paper by Fries and Bryan back in 1974, where they took normal volunteers down in the radiology suite and looked at the movement of their diaphragms when they were breathing spontaneously versus when they were paralyzed or anesthetized but breathing spontaneously. So you know when you get anesthetized, the weight of your abdominal contents is going to be pushing up on your diaphragm. So what tends to happen is you get this ventilation perfusion mismatch. When you're breathing spontaneously, the movement of the diaphragm is such that the majority of the inspired volumes comes to basically zones 2 and 3 in the lung, which improves ventilation perfusion matching. So whenever I see somebody do an APRV and they're paralyzing their patients, that's why the two things are virtually indistinguishable with pressure control inverse ratio ventilation, and really tells me that you really don't believe in APRV. So people always say, well, what are the evidence? And this one gets shown a lot by article by Christian Putenson, who I think is a brilliant physiologist who works in Europe. He took 30 patients, all with multiple trauma. If you know anything about ISS, an ISS of greater than 36 is associated with a mortality rate of at least 50%. And here's the tricky part. So he put some patients on APRV, then the other patients he put on pressure control. And those patients that he put on pressure control over here, he made sure that they were paralyzed for the first 3 days of mechanical ventilation because he wanted to prove that it was the spontaneous breathing of APRV that made things get better. And I'm not going to bore you, but there's no difference when the patients go into the studies in terms of how sick they were. And you start looking at the outcomes. Well, ICU stay, a little bit better with APRV. Duration of intubation, statistically better with APRV. Duration on the ventilator, better with APRV. No difference in outcomes, so people don't live longer. And I think what most people take away from this study is that while you get a guy who's a brilliant clinician and physiologist attacking a problem and trying to demonstrate the ability of the spontaneous breathing to be effective, and what you end up with is possibly demonstrating that not that APRV is better, that indiscriminately paralyzing patients for 3 days is probably not very helpful. Now, there have been a couple of papers in respiratory care reviewing the issue of APRV, and this one's by Tim Myers and Neil McIntyre, and kind of looks at the different authors and what the study designs were. They're almost all crossover studies, and they all find this kind of the same things. Lower airway pressure, if talking about plateau pressure, less neuromuscular blockade, better oxygenation, but again, nothing that ever shows any improvement in outcome. So from my standpoint, I actually think APRV can be very effective in the select patient, the patient who has significant lung consolidation, somebody you get transferred in from another hospital where they've been managing them on 2 of PEEP for the last 10 days because they're afraid to turn the PEEP up. And APRV is an advanced mode. It's not a new mode. It does take some time to understand how it works. And again, I'll refer you to some of those papers from the guys at the Cleveland Clinic, which I think have done a good job of demonstrating both the positive effects and the potential negative consequences of using APRV. I would never use APRV in all patients. I just don't think it's not the answer. APRV can be lung protective, and APRV cannot be lung protective, and it's our job to make sure that if we're going to utilize it, that we utilize it in a lung protective fashion. Okay, high frequency ventilation, there are lots of them. At this point, high frequency oscillation is pretty much the one that gets used the most, and this kind of gives you that idea. So you have this piston moving back and forth and this fresh gas flow that not only adds to the tidal volume when the piston moves forward, but helps wash out CO2 when the piston moves backwards. And the low pass filter is, probably ought to come up with a better term. If you know what a low pass filter is, you got it made. But it basically allows a low flow at a low pressure to travel through without much resistance, but at a higher pressure and higher flow results in the greater resistance and helps maintain the mean airway pressure. So this is kind of a look at the difference between conventional ventilation and high frequency oscillation. And I think this is important too, just like with APRV, that as you go from the airway, where you can see it on the ventilator side of the endotracheal tube, to the trachea, to someplace distal in the lung, while the mean airway pressures might be fairly consistent, you don't see these big swings in the airway pressures like you do out at the airway. I think a lot of people get afraid when they see these big airway pressure changes with the oscillator out near the endotracheal tube. But all that gets attenuated, and of course it matters how much it gets attenuated has a lot to do, probably more than anything, with the endotracheal tube size, but also with the frequency that you use, whatever the percent I time is, and what the patient's resistance is. Theoretical advantages of high frequency oscillation: small tidal volume, reduce volume trauma, and be lung protective. Having a modest, not a low, not a high mean airway pressure, you can get recruitment and reduce atelect trauma or shear force injury, prevent O2 toxicity, and because you have reduced lung stretch, you might have reduced biotrauma. Again, these are theoretical discussions. Tom Stewart from Canada gave me this slide. Frankly, I always tell people this. I work in a 35-bed surgical intensive care unit, and we don't own an adult high-frequency oscillator. And I think that just goes to show that everybody has their preference for what their refractory hypoxemia algorithm is going to be, but we have not used high-frequency oscillation in those patients. But I think this is a fairly impressive picture. We have a patient on the left with a pressure control of 20 on a PEEP of 18, so the peak pressure is going to be 38, with a mean airway pressure of 25 on 100% oxygen. And they do it a little bit different. So PO2 is 117, but the PCO2 is 72, and the oxygenation index, which is usually used with neonates, not adults, is 35. And that same patient placed on high-frequency oscillation at 4 hertz, a mean airway pressure at 32, with a pressure of 72 and an FiO2 of 0.6, and you end up with 7.2, 71, and 60. So you're able to get the recruitment and have a good PaO2 at a much lower FiO2 and have improved CO2 elimination. And, this has always impressed me. I haven't had the opportunity to see this happen myself, but it gives you the idea of what high-frequency oscillation does. But I think one of the things you should remember is that here the PEEP is 18 and the mean airway pressure is 25, but over here the PEEP essentially is equal to the mean airway pressure. So one of the reasons that things have changed so dramatically is the ability of high-frequency oscillation, like APRV, to potentially give higher end expiratory lung volume because of the higher pressure. Well, can you do high-frequency oscillation in adults? I could have picked a bunch of different studies, so let me just show you one that I think is helpful, because it's, I think, from a very capable group at Johns Hopkins looking at this very high-frequency ventilation, so up to 15 hertz. They had 30 patients who failed conventional unprotected ventilation, and they used guidelines based on another paper they did in a roundtable discussion. And here you see some of the data about the patients that they enroll in their trial. And here are the number of patients that they used, how many patients they were able to manage with this technique. So 20 of 30 patients had adequate gas exchange at greater than 7 hertz. 18 to 30 reached it at 9 hertz, and 12 to 30 at 10 hertz. And they said that most adults can be managed with this high frequency well above 5 or 6 hertz, and it can reduce tidal volume and might reduce ventilator-induced lung injury. And Dr. Fessler, I think, is one of our great clinical trialists here in the United States. Well, what about all the evidence then? Well, there are 12 observational studies, almost over 350 patients since the late 90s. Most of them show it's safe, it improves oxygenation, and most patients can be ventilated. There is the one trial, usually referred to as the MOAT trial, that was run by Steve Durdak down in Texas. And you always get to hear this event here that HFOV was associated with a much lower mortality. Another multi-center trial down here by Bolin that was published in Critical Care, no significant differences in mortality. But I think the data really come out if you look at it carefully without a bias. Again, I don't dislike high-frequency ventilation. I don't think it's great. I think it's an option if that's the way you want to go. And this Cochrane review says, few data exist to suggest that there may be some clinical benefit to HFOV. Larger trials that incorporate the current standard of practice, that's the biggest problem. HFOV hasn't been compared to lung protective approach based on ARDSNet that have adequate power to detect clinically significant differences are needed before any conclusions can be drawn regarding its relative merits. So this is the data you'll often see from the MOAT trial, and they'll say, wow, look at that. It's an impressive trial. But the simple fact of the matter is this study didn't have enough people to prove that. It was a safety trial for FDA, and it showed that HFOV was not less safe or more safe than conventional ventilation, that it was equivalent. So I think it's not appropriate to take that study in a real scientific sense and say, well, high-frequency oscillation is clearly better than conventional support. Having said that, I like to compare the two because I'm sure you've all seen this slide before. This is this idea that there's a safe area for ventilating the patient above which you set the PEEP to prevent atelectasis, and above which if you go too high with pressure or volume, you cause volutrauma. And high-frequency oscillation tends to operate on the downside of the PV curve of that technique, and APRV, I think, possibly works more on the front side of this PV curve. And so they're very similar in what they're approaching. I don't know if they're similar in patients. We don't know if one is better than the other. We just know that they're two options for an advanced mode. Now, I don't have time to talk a lot about jet ventilation or high-frequency percussive ventilation. What I'm going to say about jet ventilation is, at least in adults, which is where my frame of reference is, this is the adult acute care section, it doesn't get used very much. My experience tells me that a lot more neonatal ICUs and pediatric ICUs are using high-frequency jet ventilation as an alternative to high-frequency oscillation. I think a lot of that is because of the fact that HFO hasn't changed much, and hasn't changed at all in the last 25 years. And we look forward to seeing new devices for that technique. Now, HFPV, the VDR, vector bird stuff, probably the most recent paper is by Kevin Chung, who's in the Army. Actually, I talked to Kevin the other day. He's on his way to Afghanistan. He looked at high-frequency percussive ventilation versus a low tidal volume, exactly what we've been talking about, low tidal volume strategy in burn patients with acute respiratory failure. And he found that the low tidal volume ventilation strategy resulted in failure to achieve the ventilation and oxygen goals in a higher percentage of patients and required more rescue ventilation. So patients with on conventional ventilation went onto the VDR or went onto the oscillator or went onto ECMO. I never doubt Dr. Bird at this point. High-frequency percussive ventilation is definitely a new method of ventilation. We often see improvements in gas exchange. The problems that we continue to have is the monitoring with the VDR is not as sophisticated as you get with the ventilators that we're using consistently, and simply looking at the manometer on the top of the machine is not sufficient. And we need to know when we have patients on the VDR and they have better gas exchange, at what pressure cost, at what volume cost is that with respect to ventilator-induced lung injury. People always say, well, Rich, you published stuff about the VDR, and we did in the 80s. When the VDR was being compared to what else we had, an MA2 or a BEAR2, I think the VDR had huge advantages in some of the capabilities that it had compared to conventional sophisticated microprocessor ventilators. Now, I think the monitoring is better with those devices. I think unfortunately, 30 years after Dr. Bird first introduced this, the jury's still out. In some people's hands, they're very successful. Other people don't use it at all and don't see the need to use it. But it's an advanced mode that should be, if you're going to use it, you should use it with care and think about monitoring the volume, which can be done with a number of pneumotachographs you can put between the VDR outlet of the phasotron and the patient. And I'm just going to leave this with you. This is from Carl Haas in the University of Michigan. Their approach to failure of the lung protective approach. And so you can see that they basically, if they fail lung protection, they consider giving recruitment maneuvers, prone positioning, or inhaled nitric oxide. Then they consider pressure control inverse ventilation. If they're spontaneously breathing, then they consider APRV. If that fails, then they consider nitric oxide again, then high frequency oscillation, and then ECMO. And I think my message here is you might change these colored boxes in a preference that works within your system. But the most important message for me to give you is that the time to determine what your refractory hypoxemia algorithm is not at 2 o'clock in the morning the first time that you have a patient who has refractory hypoxemia. So I'm going to leave you with APRV, HFO, HFPV, all have potential uses, but the key is to use them in a lung protective approach. I'm not going to talk about APRV for synchrony, but that's one of the potential techniques. The other new modes that I was asked, well, when do I use PAV and why would I use NAVA? So let's talk about those real quick. So NAVA is diaphragmatic triggering and control of the ventilator. It triggers from an esophageal catheter with this array of electrodes. It has been used in what's called target drive ventilation in a couple papers, not only to trigger the breath, but to turn it off. The signal is produced by the diaphragmatic contraction and cycling at relaxation, usually 80% of the peak diaphragmatic signal. It does require that you put a 7 French catheter in adults or an NG tube that replaces your current NG tube. And it's very innovative. I mean, in terms of being able to trigger and cycle in the face of leaks during non-invasive ventilation and in neonates, and I'm always telling people, in an adult who breathes 16 times a minute, changing the trigger delay by 5 or 10 or 15 milliseconds probably is of very little consequence. And a kid who's breathing 90 times a minute might make all the difference in the world. And it makes sense to me that diaphragmatic or NAVA would be very useful in patients who have severe intrinsic PEEP that you can't get around. So it uses this technique using the electrical signal of the diaphragm. I'll show you a quick picture. It does require an interface between the device and the ventilator, and at this point only is available on the Mackay ventilators. The catheters are about $200 per patient, and the addition of the module is about $10K per ventilator. But it does have potential. So this is from the original description by Krister Sindeby of where we are right now with triggering the ventilator, all these things happening on the left, and we monitor what happens in the airway flow. In his technique, I actually kind of like to move this down to diaphragmatic contraction, one down from where he has the new technology, but clearly is a move up to trying to improve patient ventilator synchrony. So here's the drawing, and this is a picture that you'll see with the Mackay device showing you the module here that plugs into the ventilator and the catheter that's in the patient for control of the ventilator. This initial study by Sindeby was all done in normal volunteers, not on any patients. But I think the one thing that it is impressive about is if you're basically comparing airway pressure triggering to neural triggering, and then airway pressure triggering on the top right over here to neural triggering. And what you have is that you rarely have missed triggers in the presence of the NAVA catheter. Okay, you can have them. I have seen them in patients I've done it in, but it's one of the advantages. And so here is from a paper in respiratory care evaluating the use of the NAVA catheter, and you can see the EDA-DI signal on the bottom, the volume delivered, the flow, and the circuit pressure. And the blue is the airway pressure, and gray is actually essentially what's considered the NAVA pressure. And here's the case where you see a missed trigger in a patient in the second panel. And this paper in respiratory care, I think, is very helpful, talking about whether NAVA is an important new tool, or is it just something that is kind of something that we all think is interesting but won't actually impact outcomes. Another look at that same paper, looking at how the use of NAVA improves the cycling with the patient's neuromechanical demand. So you can see that in this second, let's look at the first panel. Again, the gray is essentially the NAVA signal, and the blue is the airway pressure signal. And if you look at where the arrow is between the lines, this is the time when you want to have exhalation. And you can see that in the second panel, that this is a case where the ventilator is continuing to deliver gas even though the patient would like to end the breath earlier than this. So there appear to be some advantages with NAVA in terms of improving patient ventilator synchrony, particularly in these cases. This is a paper from Jennifer Beck, who actually, I believe, is married to Christer Sinderby, who developed the technique. But this is in pediatric patients looking at neural timing and how often the neural time is up here on the left, top left, and then this is the actual ventilator timing. And look how long conventional ventilation in these neonates results in exceeding how much time the patient would like to breathe. And they found that the differences in synchrony and asynchrony were significant looking at NAVA in this population. So I'm going to tell you that to date, the outcome studies with NAVA are really lacking. It really seems to make a lot of sense, and I don't work in neonatal ICU at all, but occasionally I'll wander up there, and I've seen them take kids who are on conventional ventilation on a servo I and not using NAVA, put the catheter in and just capture the patient completely, and it seems to make a huge difference. Again, that's just my anecdotal report. It's not all patients, but in some patients it seems to make a difference. Clearly, the biggest problem we have in non-invasive ventilation is leaks. Well, if we could trigger from NIV, NAVA with NIV, it would seem to be a clear advantage, but you're going to still have to ask the patient who's short of breath and you're trying to gain their trust to accept the mask, do you mind if we put an NG tube down you? And I'm not sure that that's the answer or not. That's going to be the real issue that somebody has to answer. If it turns out putting NG tubes in patients who need NIV improves the success by 50%, clearly we're all going to do it. If it's only a little bit of a change and we have patients who have vomiting or some other issues, and trust me, getting an NG tube, regardless of what anybody says or the people at the booth wandering around with those catheters in their nose, is not comfortable, and you don't really want one if you don't need one. But it's a promising technique for patients in invasive ventilation where either intrinsic PEEP or leaks complicate triggering and synchrony. Again, all I can do is tell you, in our adult ICUs, we probably use NAVA 8 or 10 times a year in some patients who we really have trouble with ventilator synchrony. And the cost is not inconsequential. The other issue people said was, well, what about PAV? It's been around for a long time, and it has. And again, the proposed advantages are proportional assist is based on the equation of motion for the respiratory system. So as opposed to pressure support, where regardless what the patient does, you get the same pressure, PAV gives you a different pressure. The more you want, the more work the ventilator does. And it kind of makes sense. You do get a variable volume. Clearly, PAV over and over again reduces missed triggers and improves synchrony. It does, like NAVA, adapt to patient's neural control without the addition of the NG tube, but there is a limitation there we'll talk about at the end. And because, I tell the residents these days, the older I get when I give my lecture to our ICU residents, don't really care what mode of ventilation you use. Just make sure the tidal volume is lung protective, provide enough PEEP to prevent alveolar collapse, and let the patient at least trigger the breath so that they have some spontaneous effort. If you can do that, I don't care whether you do that with assist control or PAV or pressure support, but those are the keys, and know when to use something else. So here's an idea of what happens with varying demand with pressure support. See if I can explain this. This should be fairly easy. So pressure support, same pressure on every breath. But if the patient takes a big tidal volume, they can lengthen the inspiratory time. Okay. Compared to this breath over here. Or they can even have a really short inspiratory time and a really low tidal volume. But the amount of work the ventilator does doesn't change. Okay. With PAV, as you change the patient's level of desire, so esophageal pressure becomes more and more negative here, then the ventilator gives more and more airway pressure. So it makes sense. The more the patient wants, the more the ventilator does, which is different than pressure support, which does no difference, and exactly opposite of things like PRVC, which the more the patient does, the less the ventilator does, which often is not our goal. There have been a lot of studies. I know this is an old one, 10 years now, a little bit difficult to see, I guess, but these are changes in their respiratory workload. They'll have people rebreathe CO2 or put sandbags on their chest, and what you end up seeing is that when the patients are on PAV compared to pressure support, the pressure time products are lower, the work of breathings are lower, and the patients have better synchrony. PAV does seem to result in fewer missed triggers, and this is a graph that was produced by Magda Yunus, who developed the PAP technique. I like to show this for a couple of reasons. One is you get to see this esophageal pressure stuff down here, and you see all these efforts. And then when the patients are on pressure support, you get to see all these efforts, but only 1, 2, 3, 4, 5, 6, 7, 8 actual breaths, even though the patient's breathing 20 times a minute in there. But one of the things that happens with PAV that I think people need to learn to accept is that the patient kind of picks their own respiratory rate. If you get scared because patients breathe 30 times a minute, you probably don't want to use PAV. Or if you're going to use PAV, you need to learn to accept the fact that because the airway pressure is lower, because the patient has better control, even though the respiratory rate may appear to be higher than it is in pressure support, the synchrony is better and the patient's comfort is better. I find a lot of people have trouble with that, and it's a matter of understanding the technique, what it's doing, and how it works. One of the interesting things about PAV has been shown in patients who get during sleep, that the number of arousals per hour are higher during pressure support versus PAV, and this comes from a pretty simple explanation. You're on pressure support and you breathe until your CO2 falls below a threshold, then you'll have a period of apnea, and then when you go back up above the threshold, it tends to kind of startle you and you take another breath. And that's usually because the pressure support is set too high and you're getting too big a tidal volume. On PAV, since the patient's controlling it, the sleep quality is better and there are fewer arousals, and that's been shown by a number of people now. This paper from Greece with Dimitri Georgopoulos' group looking at pressure support versus PAV. So this is like a Kaplan-Meier curve. So as the line is falling, these are the number of people who remain on spontaneous breathing, not having to go back to a mode with a set rate. And you see that the patients on PAV are much more likely at 48 hours to still be breathing spontaneously than the patients in pressure support. And they attribute that to the prevention of missed triggers, the improved synchrony, and the better overall sleep patterns that occur with PAV. I like this graph about PAV because I think it's instructive. So we're talking about missed triggers, and I was saying earlier, I've never been on a ventilator, but I guess if you want a breath and you don't get one, that's probably the worst kind of asynchrony. At least I think it would be. I'm just guessing. So here are patients breathing on the horizontal axis and the ventilator rate on the vertical axis. So here in pressure support, look at all the times that the patient is breathing many more times than the ventilator is giving them a breath. That's because of the issue of missed triggers. When you switch to PAV, again, these are a ton of measurements in these patients, that happens much less frequently. Limitations of PAV. It does have to measure online elastance and resistance, which seems to be taken care of at this point. Leaks can really complicate PAV and make it difficult to use. And the weakness of PAV, in terms of compared to NAVA perhaps, is that it can't overcome autopeak, because PAV can't do anything until the breath is triggered. So in terms of work of breathing, if your work of breathing is caused by intrinsic PEEP, it's not going to be relieved by NAVA unless NAVA helps reduce the intrinsic PEEP by preventing air trapping and auto PEEP. So in terms of these two techniques then, PAV definitely improves synchrony and improves sleep quality, facilitates spontaneous breathing, but we don't have a lot of improvement in outcomes available. Compared to NAVA, I think, in NAVA you have the cost of the catheter, the placement of the catheter, keeping it in the right place. It's really, I think, technology intensive, but for respiratory therapists that might be great. On the other hand, and you're able to overcome the issue of auto PEEP. With PAV, you don't have the problem of the catheter, the cost, the technology increase, and get most of the advantages outside of the ability to overcome auto PEEP. So I'm going to try to get done here in case you guys want to comment or have questions. I don't care what advanced mode you want to use and what you call it. The guiding principles in the patient with hypoxemic respiratory failure are to use lung protection. You can do lung protection with APRV. You can do lung protection with high-frequency oscillation, with pressure control, and you'll be successful. But if you don't use the techniques properly and aren't careful, you won't do lung protection and you won't be successful. The guiding principles of patient ventilator synchrony, missed triggers in COPD patients are the most commonly reported types of asynchrony in the literature, and improving timing, syncing the ventilator inspiratory time with the patient inspiratory time are the things that you want to do, and you can do that with PAV and NAVA, each with its own advantages, each with its own unique disadvantages. But I think, and maybe after all this time, I spent a lot of time, and not that there's anything wrong with working for a company or selling products. I mean, that's the way we do things. But it really doesn't matter whose ventilator you use. It really doesn't matter if you have one or all of these techniques. What really matters is you at the bedside and your brain power and knowing how to use these techniques so that you still meet the principles. So if you can reach lung protective principles with IMV or APRV or assist control, there's no advantage of one over the other. If you can meet synchrony principles with pressure support or PAV or NAVA, there's no advantage of one or the other. So it really comes down to the people at the bedside using the right technique appropriately more than the technique or the device that we use itself. And that's my new soapbox for the next 3 or 4 years before I stop working. So I'd be glad to entertain any questions or
Rich, I want to thank you
comments.
for a terrific overview of the advanced modes of mechanical ventilation. It's a lot of information, but it was very well organized, and it was absolutely riveting, and thank you very much. And thank you again for reinforcing the value of the most important asset we have as therapists, and that's our brain, rather than just simply relying on technology to push us by. There are some questions, and there are more questions than there is time, so without further ado, I want to try and get to some of those questions for you. I'm going to start at the beginning and kind of work our way through. Richard, there was a request for you to please explain the reduced transfusions during ALI and ARDS. You mentioned that. Go ahead.
So, yeah, there are a couple things with blood component therapy is very important, and let me not get too long-winded. So we use blood, older and older blood all the time, and the reason that we're able to use it is because of studies that are done that show that there's so many viable blood cells still left after 45 days. So if you need a blood transfusion today, you're going to get the oldest unit on the shelf because that's the unit that's about to expire and the blood bank's going to lose money. But older blood tends to have complications in terms of oxygen delivery, in terms of increasing your infection risk. So while if you need a blood transfusion, if you need one, you've got to have it, it's important to have it. But giving blood transfusions to people on the margins who maybe could get by without one, by lowering the trigger transfusion thresholds, you get reduced incidence of transfusion-related acute lung injury, less infectious complications, and patients get less ARDS just simply by getting less units of blood. The same thing goes for the issue of having male donors. Female donors, because of the hormones with their plasma, can actually create problems, especially for male recipients of plasma.
Joe D raises an interesting point to reflect on here. He says, for RTs who are not utilizing ARGNet on patients with PF ratios of less than 200, might this be considered negligent care?
Boy, I would not want to go into a courtroom and have the plaintiff's attorney look at me and say, what were you guys thinking? The guy's got bilateral infiltrates on his chest x-ray, he's got pancreatitis, he's got a PF ratio of 150, and you got him on a tidal volume of 12 mLs per kilo. You should have known better. And now, if the patient's PO2 was 30, and you said, well, he could either die of hypoxemia or we could try to circumvent this, it would be a different issue. But I hate that word negligent, but you certainly would be outside of the standard of care of practice.
Mm-hmm. Mm-hmm. Richard, in your presentation, you mentioned the term VDR. Some of our participants missed the definition of that. What were you referring to there?
Okay, so Dr. Bird invented the volumetric diffusive respirator, which is essentially, the device is a sliding venturi at the airway. Think that it basically does pressure control. And actually, I think Dr. Bird's initial descriptions of VDR, how it worked, was how the guys from Downs and those guys came up with the idea for APRV. But I think if all of us raise our hand who stole the idea from Dr. Bird, it would take a while to count them all. But APR, I think that the VDR, think of it as, instead of pressure control, just pushing the gas into a pressure of 20 all at one time, you're pushing it in with 100 or 200 or 300 little bursts at a time. And at the end of each of those bursts, there's some time for gas to be exhaled. You'll never get to me to discount the VDR. I think Dr. Bird has ideas. I always tell people, I went to a lecture Dr. Bird did back in frickin' 1985 where he talked about what he called hoop stress, which if you look at the diagrams, he's basically describing ventilator-associated lung injury. Huh. And everybody dismissed it as, oh, that's just, Dr. Bird's retired and he's talking about these things. So the VDR probably, again, you can use the VDR, and I don't want to discount this either. If you grab the VDR and turn the pressure up to 60 and deliver a liter tidal volume, you will hurt people with it. It's not magic. But it is one of those things that people can use as a technique for refractory hypoxemia in selected patient populations.
Okay, I'm just trying to scan these because we are really running low on time. Here's a very practical question. How do you go about determining ideal body weight?
Ideal body weight is based on height. So for men, it's 50 plus 2.3, and then in parentheses your height in inches minus 60. And for women, it's 45.5 plus 2.3 times, in parentheses, your height in inches minus 60. And you can find that on any of the ARGNet websites.
Great. Okay, let's see. I know you mentioned that there's very scarce evidence about NAVA, but there's a question that what modes seem to work best using NAVA? Have you any comment on that?
Well, NAVA really is its own mode. And this is one, it's a real challenging educational sale. So it works like proportional assist, NAVA does. So you can put in a value to magnify the signal of the diaphragm. So you can have a NAVA level of 1 or 2 or 3. It's kind of complicated, and it actually, the interactions are very complicated as well. Actually, I think the best thing about NAVA is that it really forces you at the bedside to understand the physiology, because you can put somebody on NAVA, capture them in synchrony, and have the NAVA level set at 3, and then an hour later, now that you've got the patient in synchrony, their diaphragmatic signal, the electroactivity falls, but it's falling because now the patient's more comfortable, and you have to be able to respond to it. So NAVA is in and of itself its own mode of ventilation.
Well, Rich, again, I want to thank you for a terrific presentation. Unfortunately, there are more questions than we have time, but you got across a tremendous amount of really excellent information today. I remind everybody else and every member, I'm sorry, where am I here? If you're watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRC contact hour. And if you're watching this program as an archive, this concludes our presentation.